Thanks. Good morning. Today I'll be presenting some research on the effectiveness of dietary counseling in hyperoxaluria for patients with renal stones. This research I did in collaboration with Dr. Alex Perks and Dr. Joel Teichman. As background, it's recently been shown that oxalate actually plays a more important role than calcium in the formation of calcium oxalate stones. It's also been shown that an increase in dietary oxalate in normal subjects leads to an increase in urinary excretion of oxalate. However, it's not been shown that a decrease in dietary oxalate intake in patients with hyperoxaluria actually leads to a decrease in urinary oxalate excretion. Furthermore, we know that patient compliance with dietary recommendations in metabolic stone disease is poor. Our hypothesis was that dietary counseling for patients with hyperoxaluria would be ineffective. To test this hypothesis, we reviewed a single endourologist experience with metabolic stone disease over a 2-year period. Our baseline follow-up investigations included stone analysis, serum metabolic studies including electrolytes, calcium, phosphate, magnesium, parathyroid hormone, and a urinalysis, as well as a 24-hour urine collection. For the purpose of the study, we defined hyperoxaluria as greater than 350 micromoles per day. This is a busy slide, but if you basically follow the yellow boxes, you'll see that over the 2-year study period, 229 patients were referred for evaluation of stone disease. Of these, 73% had a stone analysis performed, and of those patients, 86% had calcium oxalate stones. Of those patients with calcium oxalate stones, dietary hyperoxaluria was found in 37% of patients. Normal urinary oxalate was found in 22%, and 7% of patients actually had enteric hyperoxaluria. Finally, of those patients with dietary hyperoxaluria, we have follow-up at this time on 68%. That's 36 patients. Demographics of our patient population at present, we have an average age of 54 years, 3-to-1 male to female ratio, and average body mass index of 27.5, slightly over normal. Interestingly, 86% of patients are recurrent stone formers in this population. Our counseling recommendations for these patients were increase in water intake, at least 2 liters a day or enough water to make the urine clear, a decrease in animal protein intake to less than 150 grams per day. Also, patients were provided with a handout on foods which represent common dietary sources of oxalate, and were recommended to eat normal quantities of these foods or reduced quantities. Furthermore, patients were encouraged to maintain a normal calcium intake in their diet. Our outcome measures included a 24-hour urine volume, urine oxalate and calcium excretion, and we tested our results with a paired t-test. This is a summary of our results showing that over the 3 to 12 month follow-up period, urine output increased slightly from 2 to 2.3 liters, although this was non-significant. Urine oxalate decreased from 553 to 471 micromoles per day, although this too was not found to be statistically significant. Finally, urine calcium did not change over the follow-up period. To summarize, 19% of patients had a decrease in urine oxalate to below the cutoff for a normal oxalate level. 39% of patients had a decrease in urine oxalate of greater than 20%. And interestingly, 28% actually had an increase in urine oxalate excretion. So in conclusion, we found that dietary counseling produces a moderate reduction in urine oxalate excretion, although not significant. 19% of patients were able to decrease their urine oxalate to within normal range. 39% were able to decrease to or by at least 20%. And in summary, we'd just like to include more patients and longer follow-up before we reach any firm conclusions. Thank you.